So good evening, ladies and gentlemen. I'm Dr. Neha Jain, and I welcome you all on behalf of Emcure Pharmaceuticals Limited to this wonderful advisory board meeting on Tenectase. Today, we'll be discussing and deliberating on the evolving landscape of acute ischemic stroke management and the role of Tenectase in that. And to discuss the same, we have with us an esteemed panel, our course director and moderator, Dr. Guru Prasad sir, our speaker, Dr. Pramod sir, and our advisory board members. I take pleasure in welcoming and introducing all our members now. I would first like to welcome and introduce our chairperson and moderator, Dr. Guru Prasad Hosurkar sir. Sir is a senior consultant neurologist at Columbia Asia Hospital, Bangalore. Sir brings with himself over 16 years of experience in neurology. He was instrumental in developing a comprehensive neurosciences unit at the Columbia Asia Hospital. He's also involved in various academic activities at the hospital, including the DNB training. Sir holds special interest in the management of Parkinson's disease and other movement disorders, and he has proctored many neurologists in DBS therapy. He's currently serving as the executive member of Karnataka Neurosciences Academy. I now welcome and introduce our key speaker for today's program. Our speaker is Dr. Pramod Krishnan, sir. Dr. Krishnan is a consultant neurologist and epileptologist, specialist in sleep medicine, head of the Department of Neurology at Manipal Hospitals. Sir is a recipient of many awards, including the Silver Jubilee Award, Dr. Anisya Vasant Memorial Award for the best postgraduate resident and outgoing student in his neurology, DM Neurology days, which was awarded by the Nimhans Institute. Sir has done a fellowship in epilepsy and EEG at the World Sleep Federation, certified sleep medicine specialist. Sir has been a speaker at various national and state level neurology conferences, and he's a member of expert and advisory groups for various research institutions. He's got his papers and chapters published across reputed journals and neurology textbooks. I now introduce our advisory board members for today's event. Our members are Dr. Uday Murugan, Dr. Manjunath, Dr. A.K. Roy, Dr. Abhinav Rana, Dr. Santosh, Dr. Veena, Dr. Surbhi, Dr. Santosh, Dr. Vivekananda, Dr. Sujit Kumar, Dr. Jaya Chandran, Sudan, ma'am, sir. I would now quickly take you all through the scientific agenda for today's advisory board meeting. After this welcome and introduction by myself, I would invite Dr. Guru Prasad sir for the opening remarks, which would be followed by an interesting session by Dr. Pramod Krishnan on the evolving landscape in the management of AIS and the role of Tenectase. After that, we'll open the panel for discussion among the advisory board members, and we'll conclude by the concluding remarks by our chairperson and moderator, Dr. Guru Prasad sir, and then the vote of thanks by Emcure Pharmaceuticals Limited. With this now, I once again welcome and thank you all for joining us here today. And I would now request Dr. Guru Prasad sir to give us his opening remarks and give us the brief overview of the program.
Thank you, Dr. Neha. At the outside, I would like to thank Emcure Pharmaceuticals for having this ad board meeting today virtually. And I would like to welcome everyone, all the panel members, speaker Dr. Pramod for this meeting. So I think in last 2-3 years, I think we had new challenges never seen before because of the COVID pandemic. And we need to pat ourselves as a neurology community because we were in one of the people who visited emergencies without missing any acute stroke patients, and we took care of them. I think I can vouch for all the, and by the way, we are also Manipal Hospital, Yeshwanthpur. We are no more Columbia Hospital. We are Manipal Hospital, Yeshwanthpur. So I and Pramod are now colleagues in the same organization. So I can vouch for all the neurologists in the city and across the country that we take great pride, in serving all our patients, especially acute stroke patients, because everyone who visited with acute stroke did not miss out on any thrombolysis therapy. Also because it was available and it is more IV, and even mechanical thrombectomy. Also, we need to really compliment our intervention specialist who took enough measures and did not miss out any thrombolizing any of our patients who required mechanical thrombectomy. So I think it's a big challenge, and I think we have really done commendable work. We can really thank ourselves that we have. I think, and it's still not ending. We've still gone through just recently third wave. Having multiple drugs, same thing will always be better. We have seen that in epilepsy. We have seen in MS. Having always better options, more options is always good, because that makes it more, availability is more, because some of the things may not be, the Alteplase may not be available, so you have Tenectase and more cheaper options. So I think it basically serves the thrombolytic therapy much more than having single drug and monopoly. So that's one. Another thing is also we will get more evidence, not only just for Tenectase, the new drug, we'll also get more evidence for Alteplase as well. So more evidence, more trials, and more data. So I think always better to have new drugs coming in the timeline, in the pipeline. And it's very welcoming to see Tenectase being used extensively in the country. And we now have Government of India, thing. There's a little confusion about thing, and Dr. Pramod will clarify regarding the window period. I again welcome all the participants, all the consultants across the city of Bangalore for this ad board meeting. And I would request Dr. Pramod to present his talk on Tenectase, the role of Tenectase in the stroke at this stage. Dr. Pramod Krishnan has already been introduced by Dr. Neha. So he's a senior consultant and HOD at Manipal Hospital, Old Airport Road. Over to you, Pramod.
Okay, I'm audible, no? Am I audible now?
Yes.
Okay. So thank you all. Thank you, Emcure, for this meeting and for this opportunity. I will be talking about something that is our day-to-day practice, managing acute ischemic stroke. And now we have Tenectase. So what is the role of Tenectase and what is the evidence in favor of it, and how does it compare with Alteplase? So this will be the main objective, to compare RTPA, that is Alteplase, with Tenectase, and review the literature regarding Tenectase in acute ischemic stroke, and to review the current practice guidelines and how each of us are managing it in our different settings. So this is a comparison of all the thrombolytic agents. We have the first generation, second generation, and now the third generation. But what is approved for use in stroke are Alteplase and Tenectase, which are fibrin specific. Alteplase is actually a mutated variant of Tenectase is actually a mutated variant of Alteplase, the primary purpose of which is to achieve a greater half-life, higher fibrin specificity, and increased resistance towards plasminogen activator inhibitor 1. So this is how they compare the chemical aspects of it. So it's highly fibrin specific, 15 times greater compared to Alteplase, because of which it is expected that bleeding complications will be less, and it might be able to lyse even older clots. And it is 80-fold more resistant to plasminogen activator inhibitor type 1. So it can dissolve platelet-rich clots and improve thrombolysis. And it can be given over a very short period, 5 seconds or 10 seconds, as a bolus dose. So these are the advantages of Tenectase over Alteplase. And based on this and studies done in India and abroad, the Government of India has approved Tenectase in 2016. The dose, which has been approved, as 0.2 milligram per kg, to be given as bolus over 5 to 10 seconds. And this is currently for the 0 to 3 hour window period of stroke onset. Beyond 3 hours, we don't have approval for Tenectase yet. So we can use Alteplase. So 0 to 3 hours, Tenectase or Alteplase, and beyond 3 hours is going to be Alteplase. So we look at some studies, some major publications where these two have been compared head to head. So this is the kind of, we have so many studies that have come up over a period of time, starting from the initial patent application to studies that have been released last year. So in this Australian study, they showed that 0.25 mg per kg of tenectase was better than alteplase. But when you look at the subsequent study, a Norway study called the NOR test, they said it was not superior, but it is not inferior. It has similar efficacy. And like that, they've looked at, we will go through all these studies. They have also looked at a higher dose of tenectase, 0.4 milligram per kg, but it did not have any advantages over a lower dose, like 0.25. So these studies, I will be going through briefly, one by one. So this is one of the largest studies, the NOR test study. It is done in 13 stroke units in Norway. It's a phase 3 randomized open label blinded endpoint study. So these were all patients who were eligible for thrombolysis, and they have used 4.5 hours as the cutoff based on the onset time or based on diffusion flare mismatch when patient had a wake-up stroke. And the dose used here was 0.4 milligram per kg, and alteplase is a standard 0.9 milligram per kg. So a large number of patients were enrolled, and in the tenectase arm, we had 549, and in the alteplase arm, we had 551 in the intention to treat analysis. But in the per protocol analysis, we had around 382 and 391 respectively. They looked at the primary endpoint, which is the MRS at 3 months, a secondary endpoint, that is short-term improvement based on NIHSS, and you had safety endpoints which looked at intracranial hemorrhage or death. If you compare the two groups in terms of outcomes, these are the primary outcome, secondary outcome, and the safety parameters, the intention to treat analysis and per protocol analysis. You can see here, there's not much of a difference actually. So the two groups have similar outcomes, both safety and the treatment endpoints. So this study, this large study, concluded that it is not superior, but it showed similar efficacy and safety profile compared to alteplase. And the dose of 0.4 milligram per kg was as safe as alteplase, 0.9 milligram per kg. But what we should keep in mind is most of the patients in this study had a low NIHSS, so it's mild stroke patients. So this may not be, we cannot probably generalize it to those who have larger strokes. But the way they used the study was similar to what we do in clinical practice. They did not use any advanced radiological assessment. They even included patients greater than 80 years of age, diabetics, those with previous stroke. So this is the kind of patients that we would be seeing in our practice. Subsequently, they did a post-hoc analysis where they focused on the moderate and severe stroke, which is not singled out in the initial publication. So they looked at moderate stroke and severe stroke, and they looked at the rates of favorable outcome and ICH and mortality. Again, here also, the results turned out to be similar. So even in moderate and severe stroke, tenectase was apparently similar to alteplase in terms of efficacy and safety. This is another large study, the Extend 1A tenectase study, multi-center prospective randomized study. Here they looked at those patients who had occlusion of one of the larger vessels, the ICA, Emcure, or Basilar artery, those who were eligible for thrombectomy. And thrombolysis was done prior to thrombectomy. Each group had around 101 patients. And in this study, they've used a dose of 0.25 milligram per kg of tenectase. And thrombolysis was done within 4.5 hours. And this was a test of non-inferiority. They wanted to see how many patients had restoration of blood flow to greater than 50% of the involved territory, or absence of a thrombus when they did angiography as a preparation for thrombectomy. So this was a primary endpoint. The secondary endpoint was the MRS at 90 days. And they also looked at early improvement. So a rapid reduction of NIHSS score within the first 72 hours. And they looked at death, symptomatic ICH. So this was also looked at in this study. So if the two groups are compared, we find that if you look at the NIH score, almost the same. And the randomization is very good. There's hardly any difference between the two groups. So the primary endpoint, that is where greater than 50% of the territory involved is reperfused and there is no retrievable clot noticed at angiography, this primary endpoint was met more in tenecteplase compared to alteplase. When they looked at the secondary endpoints, the functional outcomes, those who had excellent outcomes, rapid early improvement, deaths, and symptomatic ICH. So we can see all the good neurological outcomes were slightly more in the tenecteplase group. The deaths were slightly more in the alteplase group. So this is one study which shows that tenecteplase achieved better outcomes compared to alteplase. So this is the MRS, and you can see here also the median score of the MRS was 2 in the tenecteplase group compared to 3 in the alteplase group. And if you look at the NIHSS score at baseline, 24 hours, 72 hours, this is a median. So the median is similar in the two groups at the study time, study onset, but during the subsequent follow-up, the NIHSS score is little better with the tenecteplase group at 24 hours and remains better at 72 hours also. So this study was powered mainly for non-inferiority. So you could say that tenecteplase was non-inferior, and it resulted in a higher incidence of reperfusion of the occluded vascular territory before thrombectomy was done. And they also had significantly better functional outcomes. So this is a study that is often quoted. The same study, they tried to do it with a higher dose of tenecteplase. It's called the Extend 1A Part 2. Instead of 0.25, they tried 0.4 milligrams and compared it with 0.25 to see whether it was superior. So in this study, there was no advantages of 0.4 milligram compared to 0.25. So there was neither any improvement with respect to efficacy or safety. So we can see here the primary, secondary, and safety outcomes, no difference between the two groups. And here also, in the MRS also, no significant difference between the two groups. So 0.4 milligram, not better than 0.25 milligram. This is another study, just briefly, it's the ATTEST study. This is also comparing the two, alteplase and tenecteplase, within 4.5 hours of onset. No difference was noted in the two groups, but they felt that the fact that you have to give a bolus for alteplase and then you have to initiate an infusion which goes on for another hour, that protocol had some lapses with respect to efficacy compared to giving a bolus of tenecteplase. Subsequently, all these studies were combined and a meta-analysis was done. So 5 trials which had around 1,500 plus patients were looked at, and the baseline NIHSS was 7, and the dose of alteplase was 0.9 in all these studies, but the tenecteplase dose was variable ranging from 0.1, 0.25, and 0.4. So these are the major studies. If you look at this, the NORTEST study contributes 1,100 patients to this meta-analysis. So it's the bulk of the patients are from this study. And this study basically involved milder stroke patients. So in this meta-analysis, tenecteplase turns out to be non-inferior to alteplase with respect to safety and efficacy. But we have to keep in mind that large contribution came from one study which used milder stroke patients. So we have to keep that in mind. And the most commonly used dose was 0.25 milligram per kg. In this, these are all large vessel occlusion, but mainly involving the anterior circulation. What about basilar artery occlusion? So they have tried to take patients from each of these studies to see what happens to those patients who had basilar artery occlusion. So the number is actually very small. If you look at the tenecteplase group, where tenecteplase was administered in basilar artery occlusion, very small number of patients. And there is a registry called the Batman registry, Basilar Artery Treatment and Management Registry. Even there also, the tenecteplase is not used much in basilar artery occlusion. But even then, with these tiny numbers, when you analyze, you find that 5 out of 19 patients in the tenecteplase group had substantial reperfusion, which was significant compared to alteplase, which was only 7%. 6 out of 91 in the alteplase group, and 5 out of 19 in the tenecteplase group. So this was significant. And subsequent outcomes also not much of a difference. So there appears to be a trend that tenecteplase in basilar artery occlusion might have better reperfusion outcomes compared to alteplase, but the numbers are really small and larger studies would be required. Another point that came up during this COVID time is the advantages of thrombolizing patients with COVID. The fact that you could give a bolus over 5-10 seconds and then the monitoring could be handed over to the nursing team. The doctor, the neurologist need not really be there. Whereas if it's alteplase, you need to spend more time with the patient. So in a way, tenecteplase allows us to minimize the period of exposure when you're treating a stroke with COVID. Now, there have been quite a few Indian studies on tenecteplase. So this is a list of some of the major studies. So in Indian study, in this study, the initial study that was done, 0.2 milligram was used, found to be safe, effective, and on the basis of that, approval was also obtained. And in Kameshwar Prasad's group, that study showed that the early improvement is much better with tenecteplase. And we have the 10-wall study from Rajagiri Medical College in Kerala. They also showed that it appears to be an equal alternative to alteplase. And definitely the cost is lower, ease of administration. So it's easier for the emergency team to administer and comes at much lower price than alteplase. So in a country like India, these two may be really important factors to consider. So this is the 10-wall study from Gigi Kurutukulam's team in Rajagiri Medical College. So it was a single center study. They looked at primary efficacy outcome, which is MRS of 0 to 2 at the end of 3 months. And they also looked for any symptomatic ICH. They took 120 patients. 55 received tenecteplase and the 65 received alteplase. They used the approved dose of 0.2 milligram per kg of tenecteplase. And those who had large vessel occlusion subsequently were taken up for thrombectomy. So they looked at recanalization before mechanical thrombectomy, any intracranial bleed during the hospital stay, symptomatic ICH, and MRS at 3 months. They did not find any statistical difference between the two groups. So no significant difference with respect to safety and efficacy. This is Minu George's paper where they compared the two. And this is the comparison of the two groups. You can see that the immediate favorable outcome is much higher in the tenecteplase group. The large vessel recannulation is very poor in both the groups, so very difficult to analyze that. A lower NIH-SS at discharge was seen more with the tenecteplase group, but not statistically significant. So with regards to side effects and all, not much of a difference. So there appears to be some better improvement initially when you give tenecteplase, but at 3 months, not much of a difference. This is another study from India itself looking at tenecteplase. And this is one of there are two studies that is basically dose determining study. We know now that 0.2 mg per kg is what is approved, and that is what is recommended by the Drug Control General of India. So based on all these studies that have been published over the last few years, we now have a revision in the stroke management guidelines by AHA and ASA, where they have suggested that it may be reasonable to choose tenecteplase at 0.25 mg per kg, not exceeding 25 milligram, over IV alteplase in patients without contraindications for thrombolysis and who are eligible to undergo mechanical thrombectomy. So it can be considered as an alternative, is what they have suggested. And there's also a second recommendation where it is shown that it's administered at 0.4 milligram per kg, not proven to be superior or non-inferior to alteplase, but might be considered as an alternative for those with minor neurological impairment and no major intracranial occlusion. So we have two types of recommendations here. To summarize, when you look at efficacy, Tenectase, based on most studies, is non-inferior to alteplase, and we can't say that alteplase is superior to tenectase. And neurological improvement initially in the first few hours and at 3 months may be better with tenectase as per some of the studies. When you look at safety, there is no difference statistically, but there is a trend towards lesser bleeding complications with tenectase. And this could be because of the pharmacological factors, that tenectase is more fibrin specific, it's more resistant to plasminogen activator inhibitor 1, and has a longer half-life. Definite advantages when it comes to administration is just a bolus injection over a few seconds without any infusion pump. And therefore, the door to thrombolysis completion time is definitely less. And cost also is much less compared to alteplase. So with this, I would like to open the forum for discussion. What are the panelists' view regarding the current clinical data, and what is their practice with regard to tenectase, and how do they see tenectase when there is large vessel occlusion or when it's a more severe stroke, and what to do if a patient presents between 3 to 4.5 hours. Would you consider tenectase, or you would go by the current recommendation of using alteplase? And comments regarding the ease of use of tenectase when compared to alteplase. And in the end, should we be using tenectase instead of alteplase in most of the clinical situations that we face? Thank you.
Nice presentation, Pramod, as usual. Very, very lucid.
Thank you, sir.
About the clinical data and things. So, the same, I think, points I wanted to raise regarding that. So, is the data enough to, use tenectase side by side alteplase? That's the question. Is the data enough, and how much data is required more to use it? So that's the thing. So I think I was reading about one of the papers also, commentators, specialist, saying that there is enough data now to put it in the guidelines and thing. So good thing is the Indian DCJ has already put it into guidelines. Question is, what the debate about 0 to 3 and 0 to 4.5? That's a little confusion. So, Pramod, you want to clarify on that?
Yes, sir. All these studies that I quoted, I didn't see this distinction in most of these large studies. They looked at less than 3, but most of them have looked at less than 4.5 hours. Some have even taken up to 6 hours. And in the outcomes, generally it's non-inferior in all the settings. So I don't know on what basis here it's only under 3 hours. Is it because that is the study that was done on the data that was presented? But wherever it's used abroad, it's not yet officially approved in most of the countries, but whenever it's been used in a study, they've used it up to 4.5 hours.
Okay. I would like to now invite other members on the board. Dr. Uday, senior members, Dr. Uday, Dr. Roy, to make their comments. Can I request the host to make like a gallery? This one. Can we see everyone? And that will be good for the speaker.
I think it's a gallery only, sir.
Gallery view,
Yeah.
We would request our dear doctors and advisory board members, if you can just please put on your videos. We have opened the panel for discussion. We would like to discuss on the various touch points and the questions. Thank you, Dr. Sujit, that Dr. Pramod just mentioned. Over to you, Dr. Guruprasad. I think Dr. Sujit is here, and we'll slowly have other panelists.
So I will request Dr. Sujit can make comments on his experience with tenectase and where does he place vis-a-vis alteplase, and how does he use it in his practice?
I think Dr. Pramod has made an excellent presentation summarizing everything. So the thing is that tenectase has this advantage that it is supposed to be a very powerful fibrinolytic. number one. Number two, in a country like ours, cost is an important factor. That and the fact that it can be given as a rapid bolus, I think these three are the key points that we should take home from this presentation. And so we do use tenecteplase very often in those patients who are can't afford. We have used tenecteplase in COVID also, as Dr. Pramod pointed out. The time for monitoring is lesser. You don't really have to monitor as closely because it's not an infusion. So these are some key points. We can use tenecteplase. We have been using tenecteplase in acute stroke where there is no large vessel occlusion. What are your thoughts on this matter, Dr. Prasad?
No, most of the times I have used patients who are going for mechanical thrombectomy. Most of the time, my usage has been less, definitely, but I've been used in patients who are have large vessel occlusions, COVID, non-COVID in last 2-3 years, who are waiting for mechanical thrombectomy. Those are the kind of patients I've used. I've been a little bit careful about the window, but Dr. Pramod has already clarified a lot of trials thing. But I think the guidelines should probably get changed so that there is a legal thing also. So Emcure can work on that and make sure that we have, because if there is a difference between window period, then a lot of some of the centers, some of the physicians may feel it a little difficult to use it across the board. And even for the guidelines, we have a hospital guideline, so we can't have different guidelines for 0 to 3 and 3 to 4.5. I think if it is clear, then you can use either of them. That's one thing. So so far my usage has been in that type of situation where there is ALV, large vessel occlusion and waiting for mechanical, and so far so good. Good response outcomes in terms of thing. So now I would like to invite Dr. Vivek. You want to make comment? Okay.
Maybe Dr. Manjunath or maybe Dr.
Manjunath?
Yeah.
Okay, so we will
Guru.
Yeah,
Guru Uday.
Yeah, Uday. Yeah.
Uday. So my opinion is that initially when the guidelines came out, the first guidelines came out, I think, with regard to tenecteplase in the US. At that time, I think they had insufficient data for the trials between 3 and 4.5 hours for stroke thrombolysis with tenecteplase. That was the only reason I think they put it as up to 3 hours. I mean, both are fibrin-specific thrombolytics. If alteplase works up to 4.5 hours, why shouldn't tenecteplase work up to 4.5 hours? Yeah. Simple logic, and I think subsequent studies have just established that efficacy. I think the Indian guidelines also just copied the Western guidelines. Initially, there were no sufficiently large trials which showed tenecteplase's efficacy up to 4.5 hours. But I think that's all old hat now. I think it's been well proved. So our experience has been that we use tenecteplase even up to 4.5 hours, beyond 3 hours. And I think the results have been fairly good, maybe better. And I think we've had less bleeding complications. I mean, we've used alteplase for many years and now we've been using tenecteplase. I think we can definitely vouch for the fact that we have seen less hemorrhagic complications. And maybe, I can't say better efficacy, at least equal efficacy, if not better.
Right. So I think related to that, I think Dr. Neha and her team have shared this thing regarding.
Could I share, sir? I'm sharing, sir. I'm sharing.
Can you share that?
This is the recent.
Yeah. So this is the registry data, and it was recently, I think.
Yesterday only, sir.
Yeah.
Yesterday, sir.
Yeah, yes. It was presented yesterday. So they have shown significant, almost 50% difference between bleeding complications as compared to alteplase. So tenecteplase has less bleeding complications as compared to Alteplase. So it's a significant difference.
So this data is of 7,891 patients, sir.
Yeah.
And which has a odds ratio of 0.49. It means that 50% less chances of having bleeding with Tenectase group compared to Alteplase. And in fact, if you see, sir, the patients who are in Tenectase group were slightly higher age with higher NIHS score, which was statistically. So there's a difference between this, and it was more negative to the Tenectase. Despite that, there's a less chances of bleeding in Tenectase group compared to Alteplase.
Okay.
And coming to, sir, 4.5 hours, we are really working for 4.5 hours. So we may recently get the, we are working on that. But the approval of Indian regulatory agency is based on the phase 3 clinical study done by Genova and submitted in 2016. And at that time, it was only 3 years, and that's why it has carried forward. But in internationally, we have seen Dr. Krishnan sir has presented that all the data is up to 4.5 hours.
Right.
And sir, the dosage is also approved 0.2 in India because our study had that dosage. However, if we look at all the global evidence, even the recent evidence, they all are endorsing Tenectase with that 4.5 hours. And and most of our Indian neurologists, even with the 0.2 doses, they have found excellent results. So, yeah.
Right. So now I would like to invite Dr. Madhu, give thoughts on there are points to ponder which the Emcure wants to discuss. So question about what have you done in terms of your changes in your ER radiology to reduce the door to needle time. So that's I think the important point. Whatever drug we use, I think unless we work on the reducing the door to needle time and get down to less than 30 minutes, then the outcomes will be always a problem. So I think that's a very important point. I think we all should strive as neurologists to, make this door to needle time as less as possible. Dr. Madhu? If anyone, Dr. Santosh?
Hello.
Madhu.
Sir, Dr. Madhusudan here.
Yeah.
Yeah.
Go ahead. You heard the question, Madhu?
Actually, now, can you repeat it?
Yeah. Basically, what are the things you have adopted, changes in your hospital to improve the door to needle time?
Yeah. See, recently we were doing an audit in our hospital just to see what are the things we are going to improvise in things. See, whenever we move from one hospital to the another, that is one more thing for a neurologist to train the staff from emergency till the ICU. See, what we have done now is we have started the educative things to the emergency physicians and also to the emergency nurses, because they should know when the patient comes with a stroke, how they have to triage the patient. Similarly, what they do for the trauma. The triaging is also very important for the stroke patients. And immediately when they come, when they do this normal NIHS assessment and initial assessment for the stroke, and how they have to proceed, that they should know. What happens, all the hospitals, when the patient with stroke comes, immediately they will rush to the imaging. They will not send the investigations first. Means we have to do some investigations like blood investigations before sending the patient to the imaging, so that we can save the time. See, we have to do the PTA, INR, platelet, all these things. It will take some time for the laboratory people to give some reports. And by the time we finish the imaging, whether it is a CT scan or it may be a MRI screening, if the facility is available, and by that time we can get the reports, so that the door to needle time can be minimized by another 15-20 minutes. You can minimize, so that once the image is completed by 30 minutes, that is the goal which we have to achieve. As for us in our hospital now, more than 1 hour, which is not good for the stroke patients, right?
Correct.
Yeah. Yeah, this is how I think educating the emergency medicine staff and our stroke nurses and stroke physician assistants, that is very important because they are the one who are going to see the patients initially, and at the same time educating the local doctors, local physicians, so when they have to send the patients, and without wasting the time for imaging and all. So that is very important.
Right. Points well taken, Dr. Madhu. I would now request Dr. Veena. Where do you see the hurdles to for the door to needle time to improve the radiology? How do you work out so that the radiology happens faster? Do you do CT based thrombolysis or MRI based thrombolysis? Dr. Veena?
Hello, sir.
Yeah.
So most of the times, yes, the door to needle is very important, and door to needle, the delay is many a times the shifting and taking them to the radiology waiting time. That is the most important place where we can actually reduce. And yes, when we compare tenectase with alteplase, because after coming to Manipal, we have only been giving tenectase, and we have seen actually very good results in terms of reducing the duration for which the infusion goes on. Obviously, the infusion, there is no infusion at all, but alteplase, there used to be infusion, and all through the infusion, we need to try to control the BP and the sugars, which is not there in case of tenectase. A single bolus is all enough. Yeah, and definitely the bleeding complications have been very good. As in, not at all. I mean, at least till now, we have not seen so many complications.
Right.
Do you have any experiences to share in the large vessel occlusion also with all of us?
So, large vessel occlusion, as opposed to various studies which are these large vessel occlusions are a very controversial topic. But then there are definitely groups which say we go ahead with thrombolysis with thrombectomy. But yeah, most of my patients, at least whoever I have seen, I have tried to do a thrombectomy or thrombolysis against many of the the neuroradiologists saying not to do. But then yeah, we go ahead and do it. Yeah, I mean, this is there are many controversial things, but then yeah, I usually go ahead with thrombolysis and followed by thrombectomy.
So right, and if I can ask Dr. Santosh to make his comments on the type of patient profile he uses tenectase. There are two Santosh, Dr. Santosh NS and Dr. H. Santosh. Their experience with tenectase and ease of use and okay. Meanwhile, I'll ask Pramod and Sujit about their thing. Like for example, there's a debate where we had this discussion debate 1 or 2 years back when in our program called Manthan, where we debated whether when the patient is well within the window period for IV thrombolysis and has a major artery occlusion, whether you want to do a bridging or straight away you want to go for mechanical thrombectomy. And where do you place tenectase in that? And what are the advantages of doing bridging and thing?
I think, sir, that tenectase has probably made the debate a little easier now, because with alteplase, you had to start and then while on the drip shift to the cath lab. Here, what we do is the emergency team and the neurologist, they go to the CT gantry with the patient with carrying tenectase with them. As soon as the CT is done, if it's a clear-cut stroke historically and there's no bleed on the CT, we inject tenectase then and there on the CT table itself. And then we shift for CT angio or MR angio and then goes to the cath lab. So I don't recollect any patient where we took for direct mechanical thrombectomy when they came within the window period for thrombolysis. Almost everyone were thrombolized and subsequently shifted. So beyond the window period for thrombolysis, yes, it's only mechanical. But otherwise, in our center, the practice is to thrombolize because now it hardly takes any time. And by the time we organize the cath lab and have the interventionist in place, the thrombolysis would be done long before that.
Good. Sujit, what do you say?
Yeah, I think I agree with Dr. Pramod. With tenectase, it's much easier. It's much easier to just give a bolus and shift to the cath lab. En route, it can be given. We usually give the thrombolytic therapy only after the angio is done. So we'll have a better idea of whether there's a large vessel occlusion and all that. But yes, practice of bridging is very good and it does help, because generally door to needle time after the patient comes to the cath lab, it takes around half an hour to 45 minutes. So some time is saved, some neurons are saved. Yeah. So it's probably a good practice too. And especially tenectase makes that easier.
Right. I'll just share some information on this. Yeah, so this is one of the presentation I made, and just talking about the advantage of bridging thrombolysis. I think tenectase really scores in this. So sometimes when you do that, and when the patient is taken for cath lab, you know that around 5 to 10% is already thrombolyzed. So that's an advantage. So when you put in a catheter and take the first angiogram shoot, already 5 to 10% is already thrombolyzed. So that's an advantage, that so you're not wasting the time. The other thing is definitely it helps mechanical thrombectomy, because thrombus gets softened and you have a higher rate of reperfusion when you do a bridging. And sometimes the access to the vessel may be difficult. So you may miss out technical difficulty. You may not able to pass the guide wire to the area of thrombosis. So you may miss out on mechanical thrombectomy if there is a technical problem. So that point is always there, and there may be issue with cath lab being available, all those things. So I think we should not miss out on that. I think the centers where we have single cath lab and and especially when you are doing moving from one center to another center, but it always consider bridging rather than doing directly mechanical thrombectomy. So, and especially when there is a distal thing, for example, there is a distal embolization, and you've done a IV thrombolysis before the bridging, before the mechanical thing. So that especially with the tenectase having a longer half-life and being there in the system for longer, so the distal embolization also, the risk of having that also reduces with the thing. And sometimes we also inject intra-arterially if there is a risk of distal embolization post mechanical thrombectomy. So there are definite advantages. Speaking about the disadvantages, definitely the puncture site hematoma, which is not so high, more larger symptomatic hemorrhages as compared to just single mechanical thrombectomy. So there are ifs and buts. There are ongoing trials to compare directed thrombectomy versus thing. So we may have results in the coming years. So we wait for that. But at this, I think, stage in the type of workplace we are doing, we are exposed to, I think bridging is still the standard of care.
Sir, I have one question to ask. Can I ask?
Yeah, please.
Sir, the question to the advisory board members. So given that we have discussed there's so many practical advantages with tenectase, and we have also pondered over the benefits of thrombolytic therapy in the patients with stroke, if administered in the right window time, where do you think is the hesitancy in choosing tenectase? And what do you think is the way forward? How to encourage the use of tenectase or thrombolytic therapy overall in the management of stroke cases?
More than ad board meeting, we should have more CMEs.
Still, sir, I think why ad board? I think what role ad board plays is that here we don't really quote about the general principles. Here we talk from our clinical experiences, and what really matters is the practical scenario, the real challenges.
Basically, what I meant, sir, is basically more information. More, I think we need to meet up with emergency physicians. I think more, communication to the people, end users, basically. Basically, with the neurologists, we get updated. We attend meetings like that, but the end users, like for example, I'll give you a simple example. Like for example, now we have a lot of use of brivaracetam as an anti-epileptic, a newer drug, which is known to be very efficacious as compared to the levetiracetam. So, but it's so difficult for people in ICU and ER to change from the previous generation levetiracetam to brivaracetam. So same thing. Old habits die hard. So we need to educate people who use it. So I think we need to call, I think emergency physicians also, you need to come and meet them as well, and also educate them about the advantages. I think that will make a lot of difference.
So is that a decision, decision at the emergency in choosing tenecteplase or alteplase, as in the decision is made there? As in, I'm just trying to understand.
No, it's not like that. It's our decision, the neurologist decision, but it's a teamwork. So they also should get familiar, right? They should ask questions. They should get involved in that. So once that becomes a thing, then it becomes easier. So it's a teamwork. So basically they receive the patient, they call us, we tell them and thing. But sometimes if they are all trained to use new drug, it becomes much more easier. That's what I'm saying.
I agree, sir. Because, sir, we have lately been hearing so many personal clinical experiences of a neurologist wherein they have said that the advent and introduction of tenecteplase as a thrombolytic has made life so easy that nowadays they just thrombolize in emergency room itself. And by the time you take the patient for further workup, majority, I mean, the recanalization has already happened. So many of them, in some hospitals we have spoken. So that's where I just wanted to understand from our head board members that, okay, what is your suggestion to encourage the use of tenecteplase? One you said is the teamwork, more discussions with emergency. Is there anything else that needs to be done?
Another thing is, you said you're already working on that, the window period. I think it should be common. There should not be confusion between the older alteplase versus tenecteplase. Yes. If it is common, then there's no hesitation. So otherwise, if you have a doubt, then it becomes difficult to write the guidelines. We all have our own local guidelines in our hospital. So we have a protocol. You do this, because it's a time-based thing. So we can't waste time. So they work on that. So we can't have different guidelines for different drug. No. So I think we need to do that. Maybe with this, I think I'm reassured that I think we can probably don't need to get confused. So we can use in all the indication where we use alteplase, we can go ahead and use tenecteplase. That was a little confusion I had. But I think now Pramod had cleared now that thing that's now a lot of studies are done for up to 4.5 hours. We don't need to worry about that aspect.
Yes, sir. Only that Indian legal approval definitely we are working towards. But if you see recently there was a position statement by World Stroke Organization, and they've clearly endorsed the use of tenecteplase up to 4.5 hours, because practically if you see it's a thrombolytic agent, and the window period that meets for alteplase can easily meet for tenecteplase as well. So I totally agree with your point. We are definitely working in that. So I would also like to hear from all other advisors. Dr. Abhinav Raina, if you could just also please share your clinical experiences and share your views on how to encourage the use of tenecteplase. Yeah, he's there. Yeah, good evening. You're muted.
So first, when I did my DM and I joined my native place in Jammu, so the first...
We lost your connection.
No, alteplase in the hospital, I had to use tenecteplase. Tenecteplase because the cardiologists were frequently using in the B-town cities, C-town cities. So immediately I had to use the tenecteplase. The patient had come. Tenecteplase, definitely, if you the ER staff is comfortable in terms of they've been using in the cardiology, the acute MI setup. So I don't think there is hesitancy. I think it's just the change of guidelines that is required. Door to needle time is definitely more and more awareness of the stroke in the window period, and streamlining the door to window times, like making it faster and faster. I think it's just that we as neurologists have been trained into alteplase. Tenecteplase is a more recent thing, and more and more we use, and more we'll get comfortable, and more extensively we use. Right?
Thank you. Thank you. Is there? Yeah. Sir, over to you, sir. Guru sir. If we would like to hear from other ad board members as well.
Yeah. Anyone else wants to make any comment or share their experience? Uday?
So we are also inquisitive to know the kind of patient profiles, the different patient profiles they have been using tenecteplase in. That will also throw more light on how deep, we need to go. And again. Okay.
No, I don't think there's any difference, I think. So it's basically the window.
Okay.
Window period.
Yeah, Dr. Raina, you want to say something?
Yeah.
essentially the size of the thrombus. The large vessel occlusions, basically, it's been proven more than 8 mm the size of a thrombus. Thrombolysis really doesn't recanalize. It's the more distal, smaller M2 distal M2 and M3 vessel occlusions where you thrombolize and you get a very high recanalization rate and a definite benefit. It's the distal M2 occlusions where you are thrombolizing and are also considered for mechanical thrombectomy. There's a good chance by the time they are in the suit and you do a DSA, the vessel is also recanalized already. So bridging thrombolysis is a must, and both large vessel as well as smaller minor infarcts where mechanical, the bridging is beneficial. I still remember vividly a case. There was a large vessel occlusion. By the time the patient had gone to the cath lab, it was already dissolved and recanalized. No mechanical was required. You end up saving the cost of a mechanical thrombectomy.
Thank you. Thank you for sharing that. That's really heartening to know.
Okay, if there's no one, if there's no other comments or so
maybe Dr. Anil Kumar. Yeah.
Right. I think it was a good discussion. So I think
yes,
I think we are all ready to fuse Tenectase in a big way. That's what it looks like. I think the molecule, it's not very different. The important thing is to understand is not so different than alteplase. Right? It's tinkered molecule of thing. So genetically engineered molecule and much more specific, fibrin specific, longer half-life, plasma half-life. And so there are advantages. I don't think there's any disadvantage that come. Just that the evidence needs to reach that eventual thing. So it will come eventually. So I think we've been using a lot of molecules like that with good enough evidence now. For example, rituximab. So we've been using in multiple indications like that in immunological conditions. So the same thing, I think Tenectase, I think we should start using it to have our own experience and all. And good thing is we have Indian data. Earlier times we never used to have Indian data and we used to think. So I think we have Indian data, we have approvals, DCJ. So I think we are that way safe. I think we had a very useful discussion. Dr. Pramod presented his lecture very well, touching upon things. So we have enough evidence and enough profile to go ahead and use it much more. I think important is also to join the bandwagon of awareness, building this awareness. I think you were asking about how to improve the thing. So I think we need to reach out to tier 2, tier 3 cities and get on with the neurologists practicing in medical colleges, medical colleges, private medical colleges in outside Bangalore, cities like Bangalore, and then I think because once that information reaches them and you tell them about the ease of use of Tenectase, I think you will have much more scope of patients receiving eligible patients receiving thing. I think that's where we can expand the use of thrombolytic therapy. So I think that's one more thing. So I think we also
even
run
the importance of door-to-needle time among people. It's really, really important because once that is lost, then that's a very crucial window period. So I totally.
And also I want to invite Dr. Uday and I, our trustees of Karnataka Stroke Foundation. So we also run this program for district medical colleges for medical graduates and postgraduates. So we can also join in building the awareness. So I think that also will help both the cause and your product as well. So I think over to you, Dr. Neha and Dr.
We would also like to have some closing remarks from Dr. Pramod Krishnan, sir. So thank you so much for your excellent presentation. Truly delightful. We just like to hear from you, sir, before we wrap up.
Yeah, I completely second what Dr. Guru Prasad has said. I think among neurologists, there is always a little bit of hesitation with thrombolysis because they're also scared about bleeding complications. So those of us who are doing it regularly, we are comfortable. Those who are practicing in suburban areas or smaller cities, they may not be so comfortable. And therefore, telling them that there is a molecule that is more easy to use and possibly with lesser bleeding complications. I mean, that is a major point, especially the data you just now showed, 50% difference between alteplase and tenectase. I think that's very encouraging, and it gives us a sense of comfort using it more. So you need to have more CMEs, more meetings involving those who have used it very frequently, describing their experience to those who have not used much or are hesitant to use it. And of course, all this can be used only when the patient presents to us within that window period. So
Yes.
that's a lot of delay still happens in all the peripheral centers. So, and this is much more easier to use with less monitoring. So it may be more ideal for those kind of centers. So I think you should look beyond the metros and focus more on the smaller cities and have more meetings and programs there, because we have taken to it very, very easily. And as you know, for the last few years, it's been almost exclusively Tenectase, all types of patient profiles, all types of occlusions. And as Uday sir said, even I remember that the bleeding issues are much less. So we are very comfortable, and I'm sure everybody will have similar experience. It's just that they have to start, and we have to give them that confidence to them so that they can start it.
Thank you. So actually, sir, you're very correct. And as Dr. Guru Prasad sir also said, that old habits die hard. And these small initiatives that we are doing today, these are those small ways of how to replace those old habits by the newer habits and good habits, I would say. By your appreciation and trust in the molecule, I take the liberty of saying that replacing by good habits, indeed, Tenectase is a good molecule with the less bleeding complications. And so we at Emcure, we are already working on this. We have a hub and spoke model running wherein we are working on connecting our senior doctors at, tier 1 cities with the tier 2, 3 cities, and even in the interiors. And we are trying to just create more and more awareness, because intervention is not only required in just building a trust on Tenectase. The first intervention is required in building a trust on the thrombolytic therapy itself, in getting the first patient to the hospital to be eligible for thrombolysis, and then choosing the right molecule. So at every level, those interventions we at Emcure are doing. And I would now request our director, Dr. Swami sir, to give a vote of thanks, and we'll call it a day.
Thank you. Thank you very much, Neha. I thanks our chairperson, Dr. Guru Prasad sir, and our speaker for the day, Dr. Pramod Krishnan sir. Both have very nicely concluded the session at the end, and important points have been already highlighted. I also thank all the advisory board members who were part of this meeting. And thank you. And we have noted important points, what you have suggested, sir, conducting a lot of CMEs and all these points, and we will definitely working on this. As I mentioned, sir, we are already working for 4.5 hours approval. We are hopeful we may get it soon. So then that will also helpful for in a real life clinical practice. And the recent data which is coming from stroke and are very encouraging. We look forward that will be really help to the larger audience across the globe. With these notes, let's stop here, and we can catch up some another day with some new meeting. Thank you very much.
Thank you.
Thank you, sir. Thank you for your time. Bye-bye.